Good morning. My name is Jeff Cleaver, and I'm the executive director of the Business Healthcare Group. I'd like to welcome all of you to this special edition of BHCG's Delivering Value series, and a shout out and a very special thank you to our educational sponsor for this event, Novo Nordisk. Would like to welcome all of you that attended in person this morning and taking your time to join us, and also for all of you who have joined us virtually. So the DVS series is designed for employers, their advisors, providers, and other healthcare and benefits stakeholders to gain in-depth knowledge about the value of BHCG membership and innovative employer solutions in BHCG's portfolio. And it's really, we look at it as being an opportunity to provide a basic foundation on different subject matter that you would not have access to. So once again, thank you very much for joining us. So obesity prevalence is increasing and is associated with significant harmful consequences in one's. This morning, we are going to look with our speakers and a call out to all of our speakers and our panelists this morning for taking time out of their incredibly busy days to join us. But we will look at obesity management, its economic impact, its impact in health and chronic diseases. And we're lucky enough to have and I'll introduce Dr. Dagambi from the Medical College to speak to that more in depth. And we'll also talk about exploring options for weight loss coverage with the GLP-1 anti-obesity prescription drugs, which can not only improve blood sugar control, but also lead to weight loss. Understanding, and there is a great deal of misinformation and misunderstanding concerning this space. So hopefully one of the objectives of the program this morning is you're going to have a greater knowledge when you leave the session than when you came in concerning the issues associated with obesity. Understanding about how these drugs work and their efficacy and cost is critical for employers and health plan sponsors as they become more popular and impact benefit plans. So once again, the morning session is going to begin with a presentation by Dr. Kadambi, who's an associate professor and chief of the endocrinology and molecular medicine at Freighter in the Medical College of Wisconsin. Her presentation then is going to be followed by two panel discussions, which will be moderated by Dave Ostendorf, who's the strategic consultant for the Business Healthcare Group and Centivo's chief actuary. Dr. Kadambi, after her presentation, will participate in a panel discussion with Kevin Mead, the Obesity National Account Director for Novo Nordisk. And then our next panel discussion will feature two clinical account executives with our best-in-class strategic pharmacy benefit manager, Navitus Health Solutions, pharmacist Sarah King and Emma Holme. And then there will be an opportunity for questions, not only for those of you in the room, but also those of you who are participating virtually. And those of you that are participating virtually would enter your questions into the chat room. Once again, thank you for attending this timely critical program. And now I'm pleased to welcome our presenter, Dr. Kadambi. some reason it did.
Doesn't move up there. Advancing here. Good morning, everyone. Thank you for having me. This is a not a common type of venue for me. I usually am used to speaking to students and other medical professionals. So let's see how it goes. No, it moves there and it doesn't move here. Um, so it's advancing there, but it doesn't advance on my laptop. Okay, so just look over there. Okay, I got it. So today, so now with that all behind me, so I am really going to stick to science of obesity and weight loss in my prepared remarks. The reason I wanted to, there's a lot of controversy and about this, and benefits and things like that. But what I thought was that these are the questions that these are what we are hearing as if I go to my meeting, the Obesity Society, Endocrine Society, or American Heart. So these are the things that we as physicians and providers, this is what we are learning. And a lot of it is also going to your patients, right? So coming from the employer's perspective, I think it's important to know what the other party is hearing, and they're asking you questions. Okay, if it's doing all this. So at least I thought that that's what I would really focus on here. And so already has been talked about implications of obesity on health. And I'm going to talk a little bit about lifestyle strategies, medical management, and surgical options. Oh boy, this is really giving run for my money. So now what?
You click off on anything.
So this will start moving if I just use this.
Yep.
All right. Okay. All right. So there are two subsets of patients with obesity. So we talk a lot about patients of metabolic disease. So it is, for lack of better term, it is classified as sick fat disease by the Obesity Medicine Association, where the adiposity releases some substances like pro-inflammatory substances and other hormones that result in these metabolic conditions such as elevated blood pressure, blood glucose, dyslipidemia, and heart disease. But then there are a number of people who actually do not have any of these metabolic diseases, but they still suffer from consequences of excess adiposity, and that's classified as fat mass disease, where it's sheerly biomechanical and structural impact of obesity, which is, degenerative joint disease, immobility, sleep apnea, acid reflux, and things like that. So, what are the causes of obesity? So when we see patients, I think a lot of times people, well, now that there are these new drugs that I want to just take them and, lose weight or something like that. But I think it's very, very important to actually get to the cause of the obesity. So, really explored what are the dietary components, social and behavioral components that result in the weight gain, lifestyle, and genetics. And by being genetic, it could be really what is passed on through genes, but also just the family environment. The children learn how the family eats, also the sedentary behavior and things like that. So all of these things need to be explored. The other thing that I'm really, really passionate about is medications as cause of obesity. In healthcare, we are very, very used to starting patients on medications. We never take people off of medications. There are a number of medications that actually do cause weight gain. So 5 pounds here, 10 pounds there, that results in several pounds of weight, and that results in decreased mobility and also increase in hunger. So, at least in our program, we are very, very focused on really taking patients off of the medications that are causing obesity. And then, looking at a subgroup of people may have other hormonal causes that if you take care of them, that might result in weight loss. And, very rarely the real genes are cause of obesity. So these are the medications that cause weight gain. I mean, almost, I think it's very rare that I actually find patients who are not on these. And I really go after these first. But for me, medical management is really taking care of all the other things before I reach first. So a lot of antidepressants. I ask, so when did you get started? Well, 15, 20 years ago. Is it helping? Well, I don't know. So, same thing with the pain medications. Some of the mood stabilizers for, schizophrenia, bipolar, those I'm careful, I won't touch them, but at least I will acknowledge. So those are the people that cannot help it. They have to be on those medications. But a lot of anti-sleep medications, pain medications, again, really, they are not helping a lot of. I mean, 5 out of 10 of my patients tell me that they're not helping them. And of course, and anti-diabetes drugs. So that's a group that also causes weight gain. And then there are still a lot of providers are still using drugs that have not been shown to be beneficial in the long run for hypertension, like beta blockers. They still cause a lot of fatigue and weight gain. They're still kind of using some of these antihistamines like Benadryl for sleep and things like that. So those are all that we need to keep in mind when we are talking about obesity causes. But in the end, even with all those drugs, in the end, there is this mismatch between energy intake and energy expenditure. And that results in very high prevalence of obesity, both in adults as well as our children. So, so what happens when you treat obesity? So there are studies, there are tons and tons of studies now that show that if we take care of obesity as a disease, they will improve diabetes control, cholesterol, blood pressure. They reduce disability and premature mortality. They also improve other conditions such as like mechanical conditions such as sleep apnea as well as osteoarthritis. It can reduce certain types of cancer, improve response to cancer treatments, and reduced onset and recurrence of new cancers. Also improve fertility by taking care of conditions like PCOS, and then improve testosterone levels in men with low testosterone, and then improve quality of life, improve body image, and then some psychiatric conditions. So our patients are hearing all this and they come to us for help. So, one of the things that we had known for a long time, but it has not kind of reached everyone. And as healthcare providers, we've known that there is, in fact, weight loss is the easiest part of the whole obesity journey. I can make anyone lose weight. I promise you. But it's really the second phase after that first 3 to 6 months. That's when you stop the treatment, the disease comes back. It's like any other like hypertension and things like that. The treatment, the weight loss maintenance becomes incredibly, incredibly important because even if we get all the benefits of early on, but if we cannot maintain it, it's not going to. So one of the things you may have heard of this, but I wanted to talk about it. So, at any one point, 75% of Americans are trying to lose weight. So if everyone is successful, we shouldn't really be trying to lose weight. Why do we need to lose? Because we lost weight already, a few years ago. So the metabolic adaptation is something, we have learned so much in the last 10 years. It's really literally in front of my eyes, the science is changing. So metabolic adaptation is decrease in resting metabolic rate with weight loss. So all of us have burned a certain number of calories when we are at rest, and that is really for all essential organ functions, our heart, our brain, liver, every metabolic, it requires some calories, right? And there was this elegant study that was done in Columbia University in 1995 that showed that if with if patients lost weight, there is decrease in energy expenditure by about 300 calories per day. And it kind of tends to remain between 10 to 20%. So if they gain weight, they expend little few more calories. Now, this is from loss of muscle mass. So when people lose weight, they're always thinking like somehow magically our body will selectively lose muscle mass. It doesn't. It's always loses both fat and muscle mass. So that some of the weight decrease in energy expenditure is from that. So that's why we always tell the patients they have to exercise. There's no magic solution, whether it be diet or decrease in calories through any method, whether by dieting or medication or whatever it is. The exercise forms a key component. Otherwise, you will gain back weight even if you continue to use the medications. So this is the biggest loser study many of you may have heard of. So all the people that were in the study, except for one, everyone gained back weight after 6 years. And all of them were burning fewer calories, even after adjustment for their activity and their muscle mass. There is something about after weight loss, you burn fewer calories. So for example, if there's a person at 200-pound weight, always been at 200 versus someone who was 250 and came down to 200. The person who is at 200 pounds after weight loss burns fewer calories than the person who has always been at 200. So there seems like some kind of efficiency in the muscle after weight loss. So these people who have recurrently lost weight, they actually have much difficulty losing weight at the subsequent attempts. So that's what the science is telling us. So then there is other one is we burn fewer calories. With increase with weight loss, there seems to be some other hormonal changes that occur in our body. I think it must be that our own body trying to defend our set body weight. So I talked about decrease in energy expenditure. These are some of the other metabolic adaptations that occur with this energy expenditure. But these are all the hormones that increase food intake. So there are hunger hormone, ghrelin. It's extremely powerful. So we know after weight loss for 3 to 6 months, there is increase in that hormone ghrelin. And there's decrease in all the satiety hormones, the GLP-1, the agonists that we will talk about. And there is decrease in leptin, decrease in insulin peptide YY. All of these cause increase in food intake. So not only you have increase in hunger and you have decreased metabolic rate. So there have been a few studies. So this one really illustrates that if there is after that 6-month weight loss, unless there is a weight maintenance program, if the patients, these are the studies that predate any of the new drugs. So we had known that, people always focused on for the first 6 months and people stop exercising and, there is no attention paid to the weight maintenance. So, so what do we have right now? So we have really, we have to emphasize lifestyle modifications. I mean, that becomes, even though there is pharmacotherapy and surgery, that we cannot really, achieve the amount of success we would without those lifestyle modifications. So any diet is better than no diet. All diets work as long as the patients can do. So we have known that, not only there's a significant underreporting of calories, so it's very important to have that dietary program for patients. Men always lose more weight than women because they have more muscle mass and higher resting metabolic rate. And we also have to remember as we age, the metabolic rate declines by 2% per decade. So even if everything is the same, often we are not as active as when we are 18. by the time you hit 40, even if if you're as active, if you eat the same way, you will gain weight. So, but the choice of diet therapy is uncertain. Like, there's really no data to suggest one is better than the other. So, there have been lots of studies that looked at total calories versus macronutrient composition. In the end, it seems like it's really total calories, no matter how you do it. Maybe there is very slight advantage. I had to take out a lot of slides, but there may be slight advantage of a high protein diet, but not by too much. So the meal replacements, prepackaged meals, they all work, but they fail in the end because of lack of variety. Some of the fad diets are unsustainable. So in my practice itself, I don't really try to change patients' dietary patterns, drastically, because I feel like people really go back to how they were eating when they were, but really calorie control or decrease in portion sizes is what I would suggest, adding some slowly introducing different types of foods. Exercise therapy, again, it is important for maintaining the long-term weight loss. I think, again, we really do not emphasize this enough because people have a lot of disability, especially when they have obesity. So we now know that even a short burst of like 2 to 3 minutes, several times a day is actually very, very important in getting them moving and eventually to get to that. So even if their patients are not losing weight, exercise will improve many things, including body composition, aerobic capacity, and such. So now coming to the medications, so we have to keep in mind that they do have side effects. Again, medications do not cure obesity, and cost is a significant concern for everyone involved. So this is again, an old study. Sibutramine is no longer in the market, but I like to show this slide that showed that drug alone causes, yes, it caused some weight loss, but the ones or lifestyle modifications alone may also cause weight loss, but the combined therapy is important. In fact, it is a lot more important than now, especially because the degree of weight loss we are seeing with some of the medications, there is a lot of muscle loss, right? So we really have to pay attention to that lifestyle modification, eat protein, exercise and things like that. And, as we are all facing challenges with the availability and things like that, this forms really the bedrock. The lifestyle modification forms the bedrock of therapy. So my goal often is that I'm thinking, okay, maybe I will have about a year of this medication for my patient, or a few months or whatever. Can I teach the patient during that time how little they need to eat? How can I modify, they're not ravenously hungry. So can you learn how to do all these things? You lost a little bit of weight. How can I build on, okay, now you have a better mobility, right? So can I have you improve your activity so when the time comes that when we don't have the drug, you are still able to maintain that weight loss. So because I think the availability has been difficult, right, because of the so much demand. So I think this is extremely important to emphasize the lifestyle modifications. So the indications for drug therapy, I think many of you know. So BMI over 30 or BMI with 25 to 29 with comorbidities. So there are number of weight loss drugs. Again, I use all of them based on, again, there are some that are extremely effective, but there is role for some of the other ones as well. So this is a over-the-counter orlistat. This is, I have to say, I just used it in a handful of patients. It's actually pretty good drug if patients follow. This works by actually behavior modification. So what it does is that it actually prevents fat digestion. So if patients eat high-fat food, they will have a problem with a lot of GI side effects as well as fat leakage. So because of that side effects, what happens, patients are forced to change their dietary pattern, like they would eat less fat food. It doesn't work if patients are consuming high number of carbohydrates. But so it's an option. It has been around for a long time. Good cardiovascular safety data, and it's available over the counter. Again, patients are not, liking the side effects because they're consuming high-fat food. So if you did it correctly, there would be an average weight loss of about 10%. These are from the old studies. Now, phentermine, this is the most commonly used anti-obesity medication because of the cost and how long it's been around. It works by reducing appetite, so I do use it. Again, low risk patients, young, if I really just need to get some benefit to start with. Again, cost is less, but you have to be careful in whom you can use that, and there are a number of side effects that we have to keep in mind. And again, the studies are really this phentermine alone are back from like 1950s and 60s. It's been only approved for about 12-week use. So then, so the phentermine to pyramid combination, that's been available since 2012. It reduces hunger. Again, it has a lower dose phentermine, but long acting and topiramate. So again, we use the combination together separately in many different ways. And there are some side effects, but again, works in patients if you select the right patient. Um, and the other one is bupropion naltrexone combination, available since 2014. Also works by decreasing the food intake through works on the POMC neurons, the appetite centers in the brain. Average weight loss is about 7%. None of these are like you can use multiple combinations. That's what we do. Depending upon what availability is there and the cost of the medication. So the newer ones that I think will be probably the focus of conversation afterwards, synthetic analogs of GIP, GLP-1 hormone. I'm going to spend a little bit longer. So these are the 3 drugs that have been approved for the obesity indication. There are other alternates approved for diabetes indication as well. So these are glucagon-like peptides. These are natural gut hormones. And when you give it as a medication, it's a supraphysiologic amount. We don't make that much GLP-1 or GIP. So the pharmacologic effects of weight loss and diabetes control we are seeing is because of the supraphysiologic dose. So these are produced by gut cells, and they stimulate insulin release. That's how they decrease the lowering of the blood glucose, and they reduce the hormone called glucagon that raises blood sugar. So these analogs or GIP, GLP-1 receptor agonists, they mimic the natural hormone. So they are either injected once weekly or daily, depending upon the medications. These are peptides. So if you take them orally, it is destroyed by the stomach acid. So although there is oral semaglutide is available in a smaller dose, and the trials are being done with a higher dose, where the semaglutide is wrapped around with the molecule called SNAC, which actually destroys the stomach acid and allows you to take it orally. So that's trials are ongoing for the higher dose. And then the tirzepatide is a newer one that targets both hormones, which is GIP-1 and GLP-1. And there are multiple drugs that are coming that are called dual or triple agonists for different gut hormones. So the repertoire of medications is only going to increase as we in next 3 to 4 years. So these there are multiple GLP-1 agonists and one GLP-GIP agonist. That's the tirzepatide that's at the bottom, but remaining are all GLP-1 agonists. So the older ones used to be either twice daily or daily, and then since 2012 we have had once weekly medications. Many of them are approved for diabetes, and 3 of them, as I mentioned, were approved for obesity indication. So these drugs improve both diabetes and obesity. So there is diabetes trials, a number of them, and I named there are a number of trials for each drug. So that's the average A1C reduction for diabetes control. And in patients with diabetes, the weight loss is always lower compared to patients who do not have diabetes. In obesity trials, there were patients without diabetes. So as you can see, there is a higher amount of weight loss that you would see in these trials. So, so from what we know, these drugs improve blood sugar control. They reduce hunger and increase satiety, causing weight loss. We also now know that they reduce cardiovascular risk, and they improve kidney health. So most of the study drugs now have cardiovascular data. At least semaglutide was recently showed improvement in all outcomes related to cardiovascular disease. And I think the cardiovascular outcome trials for tirzepatide are coming soon. So there are a number of side effects, and so we have to slowly increase the dose: nausea, vomiting, diarrhea, constipation, a lot of GI side effects. And there are some things that we always worry about: the risk of pancreatitis and some special type of thyroid cancer. So this is one that really got a lot of press that was published, I think, in February 2024, that showed that if patients stopped the drug and went on placebo after initial treatment, there is some amount of weight regain after they stop the drug. So, but you can see that still some about 10% of weight loss is still kind of maintained, but not as much as if you continued the drug. So we really should not forget about the bariatric surgery. So I think both in terms of cost as well as for the patient themselves. So I really do recommend, this is just my personal practice, for young people without other comorbidities, I actually recommend bariatric surgery because we have the long-term outcomes data are coming out, but to me, I think that if I see a 25-year-old woman with obesity, the way the data are shaking up right now is that we have to be, to get the maximal benefit, they need to continue to take it. But we also don't know. So my experience has been patients actually overcome the effects of these drugs. So you have to keep giving higher doses. So after 3 or 4 years, and let's say if someone got like beautifully, like, the highest dose of any of these medications, I don't know what's going to happen after 4 years. Are they going to gain back the weight because they're now developed tolerance? We don't have that long-term, like 5-6 year data. So in terms of, so if I'm seeing a 25, 30-year-old for durability, I feel like surgery, at least we have data to suggest for a number of years, they improve outcomes and they also at least longitudinal data showing that they will keep the weight off. Of course, about 20% of them gain back weight, and we still have the drugs available to them. So this is what I tell my patients is that, yes, you do have to take vitamins and minerals, but at least it'll keep you from taking in large, very expensive medications for long periods of time. So that's my rationale for young, or even individuals who don't have a lot of comorbidities. They're not taking 4 drugs for hypertension or 3 drugs for diabetes. So, I think surgery should be encouraged if they qualify. So that's it. Thank you.
Thank you for the presentation. Appreciate all the information. You've once again proved to me that it's really good to have doctors because I'm nowhere near smart enough to be able to handle all those things. So a lot of good information there. I think there's a ton of questions that people will have about both what you said and where the whole world of GLP-1s and how it affects employer benefit programs go. I'm going to stick with some of the clinical and sort of pharmaceutical elements first, and then in our second panel, we'll talk probably a little more about employer benefit plans. But Kevin, I'm going to go to you first and just ask for sort of your reaction to what you heard from Dr. Kanambi, how it fits or aligns or differs from what Novo Nordisk sees within the obesity management side of things, and any thoughts you have about what she just said.
Can you hear me okay? Okay, good. First, thank you for having us here. We really appreciate the opportunity to actually be involved in this discussion, so very much appreciated. Um, and, you know, Dr. Kadambi really touched on a number of issues that are near and dear to our heart. Number one, when we started down this journey, we launched a GLP-1 for weight loss, Saxenda, in 2014. We felt it was important to help educate the marketplace on obesity as a disease because there was still a lot of stigma and bias associated with obesity. People didn't truly understand the biochemistry of what was happening in their body. We felt it was really important to actually help nurture that discussion and get people to a better place where they understand that obesity is a disease, it's a chronic relapsing disease, it's a lifelong disease, more or less, and that you're not alone. There's 41.7% of the population in the United States suffers from obesity. There's help, there's resources, and our provider community is getting up to speed on helping support patients. So that journey was really important. The biochemistry part of it and the metabolic adaptation part of it was really an important part of this because there were a lot of people that were stuck in some of the different segments. Number one, is it our environment? It's excessive calories, it's easy calories, that's really causing a lot of the problem. The psychosocial part of it was also an area that people were focused on. And then the genetic part of it really was the part of it that was the science is evolving on that part of it. So understanding it's all three of those areas and not any one of those areas that really are the primary drivers behind this. I love the fact that she called out medications that cause weight loss because that's not a common part of the discussion that takes place. So from a screening standpoint, from a consultative standpoint, I think it's really important to get on top of that and understand what's going on with the patient in terms of other medications that they're taking that that might be causing weight gain. The combined therapies of introducing sort of a platform of nutrition, behavioral support, possibly medication, and having the outcomes, as she pointed out, be exponentially better is really an important component of that. And Novo Nordisk supports that. Most of the conversations I have with folks, they talk about, well, we don't want this just to be about the drug. We want it to be about a comprehensive wraparound surround sound support system. And so we definitely promote that and support that. And we've seen the outcomes as well. They're exponentially better from a mean weight loss standpoint. And then the concomitant comorbidities, the amelioration of those comorbidities, getting those numbers to a better position really does play out much better when it's a combined component. The individualized medicine part of it is really important too. Dr. Gadambi pointed out, look, I have an arsenal of medication. I don't just use one medication. I adapt it to whatever this patient's needs are. I might rule out medications for certain individuals and rule in medications for other individuals because I think there's a common misperception that everybody immediately goes to one medication and that's the medication regardless of what the clinical profile of the individual is. So I think customized care is really an important component of this. And as a provider network, we really need to help promote and educate and work with providers to do a better job of understanding that there are more, and we promote the entire class of medication as a covered benefit. We don't just promote our particular medication. We want the entire class to be covered when we talk to employers. And then the whole concept of GLPs not being new. By 2005, actually that drug was available in 1992. It just took them that long to actually launch the drug. And God loves the researcher that figured out that you can use the venom from a Gila monster to create this drug. I mean, I don't know who had to go through that to actually extract that, but that's where the medication actually came from. So kudos to that person. So I really feel like, you know, she set the stage well in terms of just giving us a good overview of what's really happening.
Great, thank you. Dr. Kanambi, you know, obviously this is one of those things that has risen to the fore in terms of people hearing about it and seeing about it, and obviously there's lots of advertising and everything else. So from both a patient and an employer perspective, there's a lot of understanding, a lot of learning that's going on. It's also kind of sprouted up, a lot of popular press look at this, and the whole blogosphere filled with all kinds of ideas here. When you get that kind of phenomena, you often get information, some good, some not so good. if there are a certain number of sort of mistruths or half-truths that are out there that you'd like to dispel around these drugs, what would fall in that category?
So I don't know if it's a myth or so one of the things muscle loss, I think that's been both positive and negative press about the drugs. I think one of them is like a Ozempic face or that's type of thing. I think the muscle loss is real, but I think muscle loss occurs with any type of weight loss if you don't pay attention to the lifestyle modification, particularly the exercise portion of it. I think that's something that if, a lot of patients, in fact, I had a patient the other day who said, well, I wanted to see how the drug works because before I started lifestyle modifications, that's a bad attitude, right? So, it's really the other way around. So you first go through the lifestyle, and if it doesn't work, then you take help from other things. So I think it's not easy with anything. A lot of patients think like bariatric surgery is the easy way out. It's not. Every type of weight loss really requires some effort on the part of the patient. So I think keeping up the muscle loss activity, I think from the, it's very, very important. So I think I want to emphasize that. And I think there was one other kind of turn I saw was Ozempic babies. In fact, I got a question actually out of in a medical conference that is it real? So it is, because Ozempic or any of these drugs will improve, the weight and results in improved reproductive function. So it's really a result of weight loss rather than somehow these drugs increasing fertility rates by themselves without the weight loss. So I think those are, I don't know if that's what you were alluding to. So some of those things, I cannot think of all. There's so much information about that, all these things, like, I kind of, sometimes I, capture the imagination. I think all the other, so other than what I presented, everything else is a myth. How about that?
Yeah, I like that.
So I tried to, like I had one slide for diet, which was like, oh my God. So, but I didn't want to bore you.
I'm going to use that.
Yeah.
So one of the important things I heard is actually talk to and listen to your doctor, because there's a lot of stuff here. I'm going to ask for questions from the audience in just a minute, so get your questions ready, and we'll see if there's any online as well. Kevin, from the whole pharmaceutical side, and as you develop these drugs, obviously there is a long cycle of development. They're there for a period of time. When you look at the whole world of GLP-1s and weight management drugs, is this the tip of the iceberg? Is a lot more coming? Give me a projection in the crystal ball. What's the future look like?
Yeah. Well, you saw the list of nutrient stimulating hormones up on the slide. And I think Dr. Kadami referenced the fact that there's a lot of different medication that's in development right now. We've got about 20 companies, 107 molecules, 36 different medications that are viable medications. And this is typical in the pharmaceutical industry. When you find a category that has medical acceptance and the marketplace is very interested in it, a lot of pharmaceutical companies try and rush into that space, develop products, get those products to market. So this is no exception. We saw this in some other therapeutic areas over the last few years. This is no exception. We've got dual agonists coming, combination medications, triagonists coming. And when you talk to some of the researchers, we had a fabulous research facility in Seattle, 104 world-class researchers. It's all been moved to Cambridge. But you talk to some of those folks, and they'll tell you, look, we're going to have a lot of different options for individuals. And, pharmaceutical innovation happens in increments. It's usually not a home run. So you essentially move that needle. You get a single, you get a double, you get a triple, then ultimately you want to strive towards a home run. But it happens in increments. So we're going to see incremental improvements in medications coming to market. That's a good thing for the marketplace. There's choice, there's price competition. Quite frankly, some of those people that are in the research facility were telling us there's going to be over-the-counter medications as well to treat these that are going to be actually very, very effective and efficacious. So I think the market will evolve. And when someone asks me, well, are they going to be on this drug for life because of all these new drugs coming to market? My personal feeling is there's going to be patients that will move off of one drug, move to another drug. The provider will want to try this drug. There'll be a combination. So there'll be a lot of changes that'll take place over time from a medication therapy standpoint. But I think people should look at that in a positive way, that this market will evolve, it will grow. Now, the flip side to that is the economic concern. What's going to happen in terms of the spend level with a lot of these medications? Again, I think price competition will force prices down over time. Right now, we have a trend line that's going up. There's no question about it. People look at this in the context of combined diabetes and obesity medications as one trend line. So it's important sometimes to separate the two. And if I could, I want to just touch on one particular issue that I think is really important, particularly for the consultants and the employers in the audience. And that is when we look at what we see in terms of what's being referenced as a price for the drug, the price is different than the net cost. So the reference price that's out there in the marketplace, I just did a presentation for a consultant company. I found 17 different prices for our drug referenced, and none of them were accurate. So wholesale acquisition cost, an arbitrary 20% markup to get to AWP, ASP, MSP, full out of pocket, retail. There's all kinds of different cost figures out there. The key thing to look at is what is the net cost after discount, rebate, because usually higher priced medications oftentimes have a very generous rebate associated with it. The problem is that sometimes it's not clear what that line item rebate is because it's rolled up into a rebate guarantee. So you don't see the net rebate for the drug itself. You just see one number that's a brand rebate guarantee. Many of the contracts are written that way. So, I would want to encourage people to get a better understanding of what the net cost is before they jump to the conclusion that this drug is, going to be a runaway train or break the bank or whatever, because I think that it doesn't make it inexpensive per se, but it certainly makes it less expensive. And I think the WETF here in Wisconsin went through that due diligence in 2022. They looked at what the implication was going to be, $20 to $30 million in spend. They revised it in June of 2022 and essentially said, no, based on what we're seeing now, this has gone down to 12 to 17 million. They revised it again in April of 2023, and now it's at 9 to 14 million. And that's because they layered in the nuances of how many people they thought would truly get a prescription and what the net cost would be at that point in time.
Are there questions from the audience? Go ahead.
One is you had mentioned, I'd be curious what's made up and how I think the data back for you. And then secondly, you see how the effects of the pandemic has taken on this market space, really cardiovascular, weight gain, everything like that. Because obviously it seems like there's things, but I know it's been around for a while. Like it's really tough.
Yeah.
So I'm gonna repeat the question just for those who are hearing remotely. Two-part question. One was of the statistic around the 41% obesity rate. Where is that statistic coming from, and how has it developed? The second is relative to what we've just been through in terms of the pandemic, and how did that impact a number of the elements that go into the whole weight loss and weight management side of things.
Yeah. And I'd be curious to get your thought on the pandemic component. Probably saw a lot of patients into your office as well.
Yeah, so the data for the, it's been longitudinally being corrected, the BRFSS. I had a slide on it, but this is I can't really remember the full, but there's every decade or so and every so many years, the data are collected on the prevalence data. So it's a federal government organization that, so that's how we have had that map of United States with the color-coded obesity rates from back in, at least going back to 30, 40 years. So every periodically, that's what the prevalence data comes from. Now, in terms of, so I don't know if it's a pandemic. I think it was the approval of Ozempic and Wegovy with a substantial amount of weight loss is when it's happened around the same time. Because previously there were weight loss medications that I had shown. So the amount of weight loss was somewhere between 5 to 10% if they consistently took it. I must say some of the side effects, if you don't have a close follow-up, were a little bit higher. If you looked at, the Wellbutrin, naltrexone combination and phentermine topiramate, people were scared of using them because, you do need to have some expertise in using those drugs. So even though there were drugs around, they were not like easy to use, fewer side effect type of drugs. So I think it exploded after semaglutide got approved with a substantial amount of weight loss, upwards of 10, 15%. Now that happened right around the pandemic time. So I don't know if there was a direct relationship to people seeking therapy. It's really these drugs that came into the market that were with relatively fewer side effects and easy to take and not as scary. I think, Qsymia and Contrave was still kind of scared some of the providers to start. So these were the easy ones to use. So I think that's what I think it would have happened even without the pandemic.
Yeah, and I will say that on a state-by-state basis, those obesity rates can vary. On our novonordisworks.com site, we have a state-by-state analysis of each state and where they're at from an obesity standpoint. And the Health and Human Services Department, the OPM, the Milken Institute, these are all institutes and organizations that have validated where the obesity rates are today in the United States. And I will also just mention too, that when you look at this from a health disparity, health equity standpoint, Black Americans are 49.5%. Hispanic Latinos are 46.5%. So disproportionately, minorities and underprivileged folks that have sort of that ethnic component to it might suffer disproportionately higher. So I know that the FEP, the Federal Employee Health Plan, in part adopted obesity medication because of the health equity, health disparity concern that they had. So that's something to also be looking at, is sort of what your workforce makeup looks like from an ethnic standpoint, because you are going to have individuals that have even higher rates than 41.7%.
Let's see, take one more question for this panel, and we'll grab the next panel. Go ahead, Ben. So the question is opinions on BMI being used as a measure for, looking at the question of obesity, and is waist circumference a better measure? Go ahead, Dr. Khanami.
You're absolutely right. So central adiposity is considered a better risk assessment tool compared to overall BMI, right? Because there could be a wrestler who could be really muscular and can have higher BMI. That doesn't necessarily mean they are unhealthy. And then there could be an elderly individual or a smoker who have low BMI. That doesn't mean that they are much more healthier. So, but BMI strongly correlates with the waist circumference. So when we use a tool for measurement of anything, it really should be reproducible, right? So the waist circumference, it takes some time, but it's really can be, it's individualistic, someone who is measuring it. Now, where do you measure it? A little bit above the umbilicus, below. You could move, slide up and down. If there's a change in different medical assistant, how do you compare next time, right? Because it's really a hard measure to be reproducible. So I think when we are talking about something that needs to be clinically measured and month after month or year after year for comparison's sake, I think waist circumference is difficult unless you're in a research setting where the person who is taking the measurement is well trained and all these measurements are standardized. So I think for all practical purposes, BMI can serve as a surrogate for central adiposity. and it can. So in some special clinics, like our obesity program, we do measure, there are tools to measure, just like weight, you can also measure total body fat. But even that, it only measures total body fat. It doesn't measure really the central versus peripheral adiposity, right? Because central adiposity is bad, but peripheral butt and thigh fat are okay. They are actually, in fact, protective. So, but it's really hard in a clinical setting when we are measuring millions and billions of people all over the world. I think we have to use a tool that can be easily reproduced. You want to, if someone is obese in the United States, they have to have the same measurement if they get measured in, I don't know, Africa, right? So the same tool needs to be, so they have to be standardized.
And Ellen, I'm going to take one more question because I saw a hand pop up. Same question. All right. Very good. Oh, go ahead. So the question is, there's always a lifestyle modification element that goes along with this. Before we open the floodgates to all of the drugs, how do we from the employer community help address that whole lifestyle modification side? So go ahead.
Well, if I knew the answer, right, wouldn't I be like, but I will give you my opinion of that, or at least there is some data to suggest. I think people do respond to monetary like incentives, I think. I think there was I think one small study that actually showed that the gyms that have that pool money around, money that's pooled around the time of the holidays, like, everyone who doesn't gain weight and they get like $100 or something. Apparently, even that, as simple as that, actually help people keep the weight off. Now, we haven't really, I'm not intimately familiar with any plans that have done that. But I am just speculating. So some kind of, incentive for that. Again, at least not everyone will participate, but I think there might be something, the smoker, if you're not a smoker, you get a little bit of discount in your health insurance. So it is possible that those kind of monetary incentives to participate in a program might be helpful. Again, I don't have much data other than this study that talked about the holiday weight gain type of thing.
I will mention for employers, because I get asked this question a lot. There's a number of point solution vendors out there that I've seen this cottage industry just explode. We've seen a number of point solution vendors that have entered this space. They may have been in this space previously, but now they're bolting on the medication management support arm of it. So Noom, Wonder, Omada, Livongo, on and on and on and on. There's 35 of them at the last count that I saw. They're all claiming that they can do a good job in terms of supporting the patient from a behavioral standpoint, from a nutrition counseling standpoint, and many of them do. And many of them are very successful in terms of supporting the patients that are on the medication. Our data suggests that if the patient knows what's going on biochemically in their body, if it's demystified for them, they tend to be more compliant. They tend to actually take their medication regularly. They tend to enroll more vigorously in a program to support it. If they see results early in the process, then they're more motivated to continue on in that process. And so I think that's why some providers start medication earlier now than they used to potentially, because the results happen faster and the motivation level goes up and the sustainability of that is supported. So, it probably doesn't answer your question, but it gives you perspective on how many players are in this space now working to try and support the wraparound surround sound.
Yes. So, I mean, one of the things that I've noticed is that the compliance with those programs falls off after first few months. I think maybe that's what you were alluding to. So that's where maybe some kind of incentive or hold back, like, our incentive it's actually not our incentive, it's actually hold back of our salary, which you meet the metric, you get paid back. I'm not advocating something of that nature, that some reward in the end might help them to stick to these programs, because yes, I've seen a lot of them. And how do you keep them motivated to keep doing that?
We have our own program that supports Wegovy, wegotogether.com. It's free. It's health coaches, digital support, nudges, lesson learning, year-long, how to take the medication, how to dispose of the needle. It comes along for the ride, gives them affordability options. So I'm just putting that out there because I hear a lot of people say, well, how much does this program cost per member per month? And what am I going to pay for that? Might be an option to look at because it's at no charge and it's available to anyone using our drug.
Thank you. That's a great transition to the employer side of things. So I'm going to ask Emma and Sarah to come up. Dr. Nami and Kevin, if I can have you just kind of stay here in the front in case we need to refer back to you, I'd appreciate it. Thank you. And for those of you who may not be as familiar with Navitus, Navitus falls in that pharmacy benefit manager category of the fully transparent, full pass-through side of the PBM world. So it's a different model than some of the big three, where there's things like spread pricing and rebate management, that type of thing that go on. Essentially think of Navitus as a PBM really focusing on low net cost within a therapeutic class. So a little bit of different perspective. Sarah and Emma spent a lot of time with the employer community, and so we're going to get into some of the specific employer benefit programs. We did have a scheduling conflict with the other consultant who was going to be here. So you are misfortunate enough to find out that your moderator is also going to be a consultant, because after 30 years of consulting, I am still a recovering consultant. So this will be my consultant side, this will be my moderator side. But let me start sort of from the Navitus perspective. We periodically get surges in various clinical categories and in the movement of new drugs that come on. We went through the Hep C cycle, we went through all those type of things. What are you seeing in this cycle, and how does it differ, and sort of what kind of reaction are you getting relative to the GLP-1 surge?
I can take it. So I think overall, there's a lot of uncertainty in this space, just because with employer groups, you don't know how many of your employees are going to adapt or want to take a medication. So I think it's just that uncertainty that we're seeing. We are trying to work with our employer groups to help them understand, what that might look like, what the costs are going to be with those medications when they're utilized. But I think it's different, and it's such a hot topic, and there's so much in the media about weight loss that all the employees know about it and are asking about it. So I think that's how it differs from other disease states we've seen in the past.
I'll add on to that a little bit. It's a little bit of a different category of drugs also. These tend to be drugs that are either all excluded or all included. And that's not even just the drugs, but even medical management of weight loss. So that's very unique in this space. There's a few other, think about fertility or things like that, where an employer could make a decision to either exclude it all or include it all. And that's leads to some decisions that need to be made as well.
So I'm going to ask consultant Dave. One of the things that employers have done for years, and sort of where Nicole's question was going, is we have to deal with these things in the broader context of program development. What are we doing relative to sort of some of the messages we've had out there for a while, and how does this change the dialogue? In particular, I think a lot of employers have had incentive programs in place for a number of years now. Those incentive programs often were keyed to managing and improving on certain biostatistics, often looking at blood sugar levels and at hypertensive control, and at BMI, which was one of the most common ones. And we've said explicitly as employers, weight management is an important thing, and keeping your BMI and towards the normal category is far better off. And then we have at this point, a number of our employees coming back and saying, you said that was really important, but now there's these drugs that would help me meet the BMI measure that you just said was, important for me to meet, and you don't want to pay for the weight loss drugs. How we manage that kind of sort of conflicting message as we go forward. And I will tell you from sort of the advisory perspective, it is one of the tougher conflicts, and yet, we live in that world where employers obviously have to be good stewards of the money that they are spending on benefit programs. And we can't get caught into the cycle of, well, yes, you can fix everything, and we can fix everything by spending more money, both more employer money and more money from the employees on this topic. So there has to be a good, effective trade-off of where the financial commitments can go. So that whole trade-off assessment that has to be done on a regular basis is clearly part of this dialogue. On that whole financial side, let me ask Em and Sarah, that when we look at the financial management of these relatively expensive drugs, there's a lot of decisions employers have to make that do have a very specific financial ramification. And as we get to some of the things that Kevin was talking about relative to rebates and relative to money that's out there, can you help clear up some of what an employer has to do in its benefit program to have access to things like rebates?
The main thing would be following to FDA labeling. So adding this class of drugs, you can obviously have utilization management criteria. We'd definitely be promoting that, not just adding it to formulary and allowing anyone to have access, but making sure that there is correct management criteria, prior authorization that needs to happen from the physician before the member receives the drug. So it's exactly the criteria that you had up earlier, the BMI of 30 or BMI of 27 with those comorbid conditions like diabetes or cardiovascular disease. We also do have an attestation that they are maintaining lifestyle modifications as well. And then it's kind of a step approach too. So they get the initial approval that might be for 3 or 4 months, and then making sure that weight loss has occurred. So at least a 5% weight loss before there's continuation allowed. Typically, that would be a not qualification for rebates. And
The
that's
question was, if the BMI, if an employer is using a measure that is a higher BMI, for example, than the 30, do they lose the opportunity for rebates? Go ahead.
Yeah, so that would typically unqualify for them for rebates. And that's one of the things that we have to discuss is, what is that utilization going to look like for what you might pay for the drug when it's unrebated versus what the utilization might look like and the cost compare for rebated drug. One of the points that Kevin made before was knowing the net cost. Your PBM should be able to tell you the net cost. That's something that should be shared. So if they're not sharing that with you, I'd press them for that information. We can definitely share that with our clients and help figure out what that net cost of drug is.
Go ahead. Let me just make sure everybody heard that the question in the comment was, a lot of cases, if an employer puts in a program, say using a point solution, that it's a requirement for someone to get the drugs, that potentially they're hearing from the PBM that would negate the ability to get the rebate. So your thoughts on that?
Yeah, definitely. I think it's important to have that conversation with your PBM. And at Navitus, we're fully transparent, pass through 100% of rebates. So I think we have these conversations day in and day out with our clients about, would they rather have their rebate, or would they maybe try and curb that utilization by having stricter criteria? Maybe they're increasing the BMI to 35 or 40, or they're putting in like a weight loss tier or a lifetime max. Those are conversations that we have day in and day out, but as it stands right now, those would not be rebate eligible. So it really just depends on what the employer is looking to do, as far as would they like open access to the drug using PA to label, or do they want to try and decrease utilization by having more strict criteria?
Question?
I have that date. Get the data. Spending. I have an error. I used to do. I did that date.
The question was why, if I'm the employer doing, the rational thing to try to get the drugs within a program that is going to be most effective, am I losing access to the rebate? Why is that process out there? So we'll let you answer that, and maybe we'll have Kevin touch on that as well, because he's going to end up as the bad guy here. So
So the drugs are approved for a certain FDA indication, right? So they have this indication when they went through the approval process that says that they're efficacious for the BMI of 30 or 27. So that's where the company has said, this is what we have the approval for. So going outside of that on a prior auth form, and this isn't just weight loss, this is lots of drugs, going outside of what the FDA indication is may negate some of that rebate, but I'll let Kevin for that too.
Sure, thank you. Better turn around. So one of the questions regarding the actual point solutions component of that, as they mentioned up here, it's really important to have that conversation with the PBM. But I will say that if the point solutions network is an exclusive network, in other words, you can only get the drug through the doctors that are a part of this telemedicine component, that generally is rebate ineligible. Using a point solution vendor to support overall health of the patient generally is not a marker for rebate ineligibility, generally. Now, I can't speak for all PBMs, they're all different. I will say that PBMs are adopting programs now with various different waterfall rates. If you wanted to start between 27 and 32 with 2 comorbidities instead of 1, if you wanted to start at 32, some of those programs are now being brought to market, and I think things are going to continue to change over time. So it's important to kind of stay abreast of what's happening, what your options are, because you're not totally locked into one option. If you want to forego the rebate, you can do that, start the BMI level wherever you want to start it at. The question then becomes is, and I will say this, that when we've looked at the data, the average individual getting treated has a 37 BMI, and they have 3.2 comorbidities. That's the average. And I'm not saying that someone who has a 27 with some hypertension would not qualify for the drug. They do, and they could get the drug very well. But that was Cleveland Clinic data. And so it gives you an idea of sort of the natural step edit that's sort of in the system currently. But I just want to point that out because, it's important to understand a little bit about the patient type. 84% of all people getting a medication are female. 16% are male. The average age is between 35 and 55. The average utilization rate, according to Milliman, is 4.2% of the eligible population by virtue of a PA. Now, we have markets where it's double that. It just depends on the prescribing population. Because a lot of times the doctors, there's a Pareto population out there of physicians, 20% writing 80% of the prescriptions. If you're in a heavy concentrated market where there's a lot of doctors writing, you're going to see higher percentages of utilization. If you're one that isn't, you're going to see lower percentages. So all that information, working with the PBM or your other provider networks, I think it's really important to kind of understand to get the bigger picture.
So the question is, does this apply if there is a step therapy requirement up front where someone would go through some lower cost or less intensive kind of processes first, and then move on to qualifying for the drug?
Generally not. I think when you look at these drugs versus some of the other, like a Contrave or a Qsymia, I don't think you're gonna get the same clinical efficaciousness or results. So it's kind of like you're doing that when you know you could have these results on this side. So you kind of have to look at that as well. A much lower probably weight loss than you'd have with one of the GLP-1s. So yeah, I haven't seen a step, and maybe you know more, Kevin. I haven't seen a step be um, allowable if you're talking about rebates. Now, if you take rebates out of the equation, you can have lots of setups. There's lots of options that we could talk through for how you want to set things up. But for rebate eligible and probably to get to the drugs that your employees are wanting and they've seen in the media and really, let's be honest, they work. These are the drugs that are going to give them the most bang for their buck. Yeah, it's generally not advised to do the stop. Sure.
And if we start to go to some of the numbers, and this is where some of the complexity goes. If you think about having various rules in place that may mean that you're not going to receive the rebate, there's an equation out there. When you look at a number of it's a requirement that you have a diabetes diagnosis, for example, to qualify for the drug. You're talking about taking a population that may have been, a third or 40% of your people being in the eligible population down to 6%. It may be that kind of, dramatic differential. So if I've decreased my eligible population by a factor of 6, and I've given up a rebate that takes the cost from X down to 70% of X, having lost that rebate is nowhere near the financial hit to me that I get by gaining a much smaller population. So the numbers do matter. There's, thank God for the actuaries in the room. We still have a job. That's an important consideration as you look at this. So the idea of just simply giving up a rebate shouldn't be the compelling issue in how you design your program. You have to look at the totality of the numbers going forward. Go ahead. So if I encapsulate the question, just I think a question of if we have a drug like this where there's a lot of back order, where there's some supply limitations, how do I, in planning for next year, really factor that into what my expectation should be?
A couple different things to look at. So I think in general, if you're looking at adding these or something like that, we start with, I would say, about 1% of your population when it all comes down to it, of those who would be eligible for the drug, those who are willing to inject themselves, all the different things. You have to take all that into account. And then, side effects. So you might have some who do start it and then end up, having to stop it. We have seen some, of course, employer groups end up 3 to 5% of utilization, but usually starting to look at the numbers around 1%. And then also making sure that the correct group is using the correct drug. So we've got some things in place to make sure that those with diabetes are using the Ozempics, Trulicities, Victozas, and not the people who are using weight loss aren't using those diabetes drugs. So we kind of have a what we call restricted to diagnosis edit on those drugs to make sure that only diabetics have access to those. It would be nice if everyone did that because maybe we wouldn't be in such a shortage and all the off-label use happening. And then for the weight loss drugs, obviously those go through a different process, through a full prior authorization process. Now, yeah, we know that these are on short supply in some areas for sure. We get calls into that to our call center about that quite often. Probably not as much as some of the other drug categories like ADHD is happening right now, but it's more calling around, finding other pharmacies. Of course, we have some relationships with Costco and things like that. So making sure that they've got supply on hand can serve our members before we start, sending prescriptions their way. But yeah, right now it's a little bit of a scavenger hunt sometimes to find which pharmacies have stock and are able to keep up with the stock.
Thank you. I just wanted to make one comment on the supply, because this is something that's near and dear to our heart in terms of fulfilling the demand that's out there. We have doubled the supply and the distribution of the low dose strengths, and it's really been the low dose strengths of Wegovy that have been the problem. 0.25, 0.5, and 1 milligram. So this is the starting doses. It's really important to have continuity to titrate up to try and minimize the side effect component. So our machines are working, 24/7, 365 to try and catch up. Keep in mind, this is a global demand issue. We're available in 5 countries. We do business in 80. So think about the demand globally, which puts, the United States gets a priority for all the distribution. So we are still going to be catching up, but as they mentioned, supplies are going out, and we have doubled the low dose strengths. And so I would encourage an individual, if they go to their pharmacy and they hear it's not available, either contact that pharmacy the next day because shipments are going out weekly from the wholesalers, or contact another local pharmacy because they very well might have it in stock. We are shipping product. It is available. We gave priority to the existing patients, the 1.7 and the 2.4 milligram strength, because this is an API issue, active pharmaceutical ingredient. We just can't get enough of the active pharmaceutical ingredient to produce the product with the demand that we currently have. And the same is true for Lilly, for their drugs as well. They have the same exact issue. But just know that we are working as hard as we can to catch up, and we're hoping that we're making a dent in terms of the supply issue, because it's frustrating for patients and it's frustrating for the providers to hear that the drug isn't available for them. But just be persistent and keep checking back, because I think it's out there.
I actually have a question to you. So where are all these boutiques and all of these people? What's that industry grade or whatever, research grade? Is that a real component, or what is all the people are buying and taking?
So I think you're referring to compounding pharmacies. Yeah. So a couple of things. If you're an employer, you want to check your network, because we are seeing utilization come through medical spas as part of a network of an employer. That's something you want to look into, because you don't know if you're getting the medical management support if it's coming through that side of it. It's just kind of a drug play. But compounded medication is a thing. We were just talking about this before. It is a thing. When you are in a short supply, the FDA allows compounding pharmacies to produce the drug to backfill the supply problem that's out there in the marketplace. But the number of adverse event reportings that are taking place are exponentially larger The FDA has issued warning letters. They've sent letters out to all the network pharmacy operations to beware of compounding pharmacy. Semaglutide. Semaglutide, when it's compounded, it can be research grade. And literally, we've seen the vials say not for human consumption. It can be something that is counterfeit that comes into the marketplace. Oftentimes, it's mixed with salts. So semaglutide sodium, semaglutide acetate, those are not approved active pharmaceutical ingredients. The FDA does not approve those. So beware. I know that they're being marketed everywhere. It seems like I was in Las Vegas and I saw billboards all over the place for compounded semaglutide. But just beware that the FDA has issued warning letters on this, and it's something just to be vigilant about and, be careful about.
Um, Well, I should say it's an exciting time actually, as a physician treating obesity. And there is, as Kevin mentioned, there are a number of medications that are going to be in the market, targeting different receptors. As it is, I think in the short term, in the next few years, we still have to deal with the shortages and the cost. But I think, again, do not forget the lifestyle modifications. Even though I think one of the guests commented that it's hard, but any little bit helps. So I think not giving up on that. Again, the muscle loss can be real. So I think I strongly believe taking the medication without paying attention to protein and muscle loss is could be detrimental. So I don't know. Is that do it?
Again, I just want to thank the business group for having us here and being a part of this discussion. Sometimes as a manufacturer, you sit on the sidelines and discussions take place and you don't get to participate. So thank you for having us here. We feel like we are a resource. We feel like we've got information, education, support to offer. It's really inspiring to hear providers like Dr. Kadambi talk about how they are treating patients, their passion for treating patients. And the humanistic side of this is not to be overlooked. This is transformative for a lot of people. It changes their lives. It's amazing what can happen when someone is essentially suffering from obesity for so many years, and it changes their life. I mean, just the ability to exercise and walk and musculoskeletal related problems, back hip joint related issues, can improve. And so let's not lose track of the fact that this is really a good thing for people. I understand the business side of it, and I understand the sensitivities around all of that. Believe me, we're in the middle of all that. But we work with companies like Navitus to try and bring these resources out to the marketplace and support the patients, because really it's kind of about supporting the patients. So that.
I would just say overall, thanks for having us, Jeff. But these are conversations that you should be having with your PBM and being involved in the decision-making process, whether that's PA to label or working through the nuances of criteria. But just, a reminder to have those conversations. It's very important.
Thank you for the collaboration. Happy to be here. It's nice to be in the room with so many different contributors and having a real discussion about this. And like Emma said, always ask your PBM, ask what other resources there are, non-pharmacologic avenues that they probably have vendors on hand that you could talk to about, new Virta, whatever that might be, and then the pharmacologic answers as well.
So we knew we'd have a ton of interest in this topic. Obviously, you saw from the questions today, there's a lot of stuff out there. I would encourage the employers to spend time talking to each other about how they're managing this. There's a lot of good ideas out there. There will be a lot of continuing opportunity to have these kind of dialogues. I'd like to ask you all to help me thank the panel for their attendance today, and appreciate all of your time and everybody who participated both here and remotely. So thank you much and enjoy the rest of your day.
Okay, one closing comment. The Business Healthcare Group and GNS has conducted 2 physician value studies over the past 4 years. And we're getting ready to make an announcement for the 3rd version of the physician value study, which is going to be enhanced because it's going to include social determinants of health data. And we're also going to have a CMO panel that's going to support the design of the study also. So look for an announcement on that. And then we're looking to do I would call it an annual meeting sometime in July to provide more insight and detail concerning the physician value study. And even more importantly, our golf event, I think Jennifer left. We have a golf event the 3rd week of August, and I would invite all of you to participate. And every dime that we raise goes to the Sojourner Family Peace Center, and we do not retain any monies whatsoever. So with that, thank you very much for taking time out of your busy days. For those of you in person and also for those of you who have participated virtually. And there will be a recording of the session on our website within approximately 2 weeks also. So thank you very much. Bye now. And one other point. Thank you to Dennis Salentine and Melissa Del Vecchio for hosting us. They're from BMO. This is an incredible facility. So thank you very much. And also for Novo Nordisk for being the educational sponsor. Thank you. Joe, thanks.